If the research process was likened to cooking, data collection is the marketing part of research. Good day, everyone. I am Dr. Penny Adversario. We are here to learn about variables, its scales or levels of measurement, the difference between conceptual and operational definition, the data collection methods and tools, validity and reliability issues in data collection, and guidelines in the use and development of questionnaires. There are three phases in the research process where identification of variables is considered: objective formulation, data collection, and data analysis. The first basic question in data collection is, what information should I collect? This will depend primarily on the study objectives, which will eventually influence the identification and definition of study variables. In this example, a researcher wishes to determine the association between key performance indicators and depression among call center agents. The abstract concepts of key performance indicators and depression in the general objective is made more measurable under the specific objective. There are several indicators that are considered, among which are the number of calls waiting, the proportion of calls answered, the average call duration, and customer waiting time. Average call duration and customer waiting time, if expressed as minutes or hours, number of calls waiting, or the proportion of calls answered, will involve differences in data to be collected because of differences in their scales or levels of measurement. In addition, the type of information to collect will depend on how the variables are defined at the start of the study. In first year, you are introduced to two main classification of variables: quantitative or numerical, and qualitative or categorical. These are further classified according to the level or scale of measurement as nominal, quantitative ordinal, qualitative ordinal, interval, and ratio. A variable, therefore, can assume different scales or levels of measurement depending on the purpose for its use, how it is defined, and how it will be analyzed. By relationship, the variables can be classified as dependent or independent. The dependent variable is a disease or the outcome being investigated, while the independent variable is the exposure or the risk factor. The confounder is by itself a risk factor for the disease and is associated with the exposure. It is sometimes referred to as covariates or control variables. Mediators are intervening variables between the exposure and the outcome, which affects only the outcome. As an example, sedentary physical activity is a risk factor for myocardial infarction. Older age groups are at risk for myocardial infarction, and level of physical activity is related to age. Physical activity can modify obesity, which in turn can reduce the risk for a cardiac event. To further understand variable identification and classification, here is a study on factors for hospitalization among patients with prior emergency department visits for mental conditions. The outcome or dependent variable is frequency of hospitalization. The factors are grouped into domains as need factors, predisposing, and enabling factors, which are the independent variables. What is the scale or level of measurement of the factors that fall under each domain of the independent and the outcome variable? The dependent or outcome variable is frequency of hospitalizations, which are grouped or categorized as no hospitalization, moderate, and frequent hospitalization based on a range of numbers as 0 for no, 1 to 2 times for moderate, and more than or equal to 3 times for frequent. This is qualitative ordinal. Under need factors, mental disorders, which are categorized as anxiety, depressive, adjustment, bipolar, schizophrenia, and psychotic and personality disorders, are nominal in scale. Also, substance-related disorders, categorized as alcohol-related and drug-related, is nominal in scale. Chronic physical illnesses, as yes and no, is also considered nominal in scale. Under predisposing factors, the following variables are considered nominal in scale: sex as male and female, type of emergency department such as psychiatric without medical services, psychiatric integrated with general, and general without psychiatric, and psychiatric merged with general. Age categorized into age groups is considered qualitative ordinal. Material and social deprivation index categorized into quintiles, that is, index from 1 to 5 was derived from scores which were arranged from lowest to highest and subdivided into range or groups of 5. With this transformation, it is now considered quantitative ordinal in scale. Under enabling factors, the responses to question type of variables, like having a family physician, prior emergency department consultation, and hospitalization, imply a dichotomous yes-no response, which are considered nominal. Number of consultations for any medical condition, number of outpatient psychiatric consultations, number of GP consulted in primary care, and number of physicians consulted in specialized care, and number of interventions in local community health services are ratio in scale. The third feature under what data collect calls for defining variables operationally. The usual way to define variables is through the notion of conceptual definition. Dictionaries and textbooks provide us with conceptual definitions. While conceptual definition tells you what the construct means in theory, operational definition tells you how to measure it. It assigns meaning to a variable by specifying activities or operations to measure it. With operational definition, it ensures common understanding and consistency in measurement. Take pain, for example. Conceptually, it is defined as physical suffering or discomfort caused by illness or injury. Operationally, it is defined as physical suffering measured using a visual assessment score, such as the Wong-Baker Pain Scale, from 0 to 10, with 0 representing no hurt to 10 as hurts the most. Other examples are shown on this slide. Body weight is conceptually defined as heaviness of an individual. Operationally, it is measured to the nearest zero point 0.1 of a kilogram using a calibrated electronic weighing scale with the subject lightly clad. Quality of life is conceptually defined as an individual's perception of his status in life within the context of his value system. Operationally, it is defined as the total quality of life scores derived from a 16-item self-administered questionnaire which considers the four domains of physical health, psychological, social, relationships, and environment. Level of compliance of barangays on disaster management can be operationally defined either as the proportion of yes responses to a checklist, which makes it nominal, or the percent fulfillment of the criteria on each of the four thematic areas of disaster management, categorized as less than 50%, 50 to 74%, and more than or equal to 75%, which makes it qualitative ordinal. Physical activity can be operationally defined as a number of hours per week of physical activity, which makes it ratio, and also by the physical activity record bar from a scale of 1 to 9, which makes it quantitative ordinal. The second basic question in data collection is, where do I get the information? Data, according to sources, can be classified as primary or secondary. Primary is data obtained firsthand by the investigator, while secondary is obtained by other people, not necessarily those of the investigators. As such, primary data allows collection of in-depth information, and there is control on how it was collected, which is a limitation for secondary data. The researcher is left to contend with the data on hand, which may have a different definition of variables from one study definition. Example, a researcher wishes to determine socioeconomic status as a factor for smoking prevalence and uses average monthly income of the parents as the indicator, but it is not available in the secondary data source. In such conditions, the researcher is constrained to make do with what is available, such as proxy indicators for income, like educational attainment or occupation of the parents. Also, in secondary data, because the data is there already, it saves a lot of time, money, and effort in collection, which can be time-consuming and expensive for primary data. Information about disease can be obtained from registries, logbooks, and office records. Exposure data can be sourced from subjects, caregivers, or surrogate persons, and medical records. The third basic question in data collection is, how should I collect the information? There are four basic types of data collection methods: observation, interview, questionnaire, and records review. Observation is extraction of information from subjects through simple visual observation or through the use of an apparatus. The available techniques are observation of a behavior or practice, doing a physical examination, and performing laboratory tests or screening procedures. It requires skill and training in being an unobtrusive observer, in performing a thorough physical examination, as well as resources or facilities to carry out laboratory or screening procedures. With observation, there is potential for bias. And because there is need for training to ensure objectivity of the observations, it can be expensive and labor-intensive. A questionnaire can be conducted in the following ways: by sending the questionnaire to respondents via postage, hand deliver, channeling to a point person, or online, or gathering the respondents in one place at one time for community-based surveys. It can be self-administered, that is completed without the assistance of an interviewer, or interview-guided for selected population groups such as elderly and children. The advantage of a questionnaire is that it can be administered to a large group simultaneously, and this would turn out to be cheaper. With anonymity, there is confidence in accomplishing the questionnaire, and there is less pressure for an immediate response. However, one can get a low response rate, which may be a potential source of bias, since those responding may have different characteristics from those not responding. To improve the return rate to an acceptable level, say 50 to 85%, it is recommended to add an additional 20% from the computed sample size to account for non-responders. You can also do follow-up methods like telephone calls, giving of letters, advance notification prior to data collection, and provision of cover letters with return envelopes. In addition, for both mailed and online questionnaires, it may have been answered by a person other than the respondent, which could affect the validity of the responses. Also, another disadvantage is that there is no opportunity to supplement the answers by observation, and completeness of the data is not always assured. An interview is a one-on-one encounter between the interviewer and the respondent. It can be face-to-face, which is impractical for large samples. It can be via telephone, which is inexpensive and less time-consuming, but likely to be biased due to selection. In computer-assisted personal interviewing, the interviewer brings a laptop or handheld computer and enters the information directly into the database. This saves a lot of time in data processing but may be expensive, as it requires training not only in interviewing but in computer skills as well, plus the equipment. In computer-assisted self-interview by video or audio, the interviewer is not present. The advantage is subjects are more inclined to answer sensitive questions because of the absence of the interviewer. An interview is facilitated by a list of questions which may be structured, as with a questionnaire, or unstructured, as with clinical history taking or focus group discussions. Focus group discussion is used in qualitative research where small groups are brought together to discuss topics freely under the guidance of a moderator. The issues that come out of the focus group can help develop a questionnaire. It's flexible, but it's time consuming, and there could be the influence of a dominant member of the group. In an interview, you get better response yield. You can make observations during the interview. It also permits clarifications of questions from the interviewer and responses from the interviewee. But it can't reach a greater number of respondents. It is expensive and labor-intensive because of the need to hire and train interviewers. It can be time-consuming. There is also a possibility that the responses can be influenced by the attitude of the interviewer, or a respondent may have the tendency to give socially desirable answers. Data from a records review can be obtained from the following sources: from hospital or clinic records, employment records, school records, pathology logbooks, death certificates. A records review can serve as a baseline data from which trends can be established over periods of time. Being secondary data, though, it may be inaccurate, incomplete, outdated, and have a different definition of terms, as well as issues on data privacy. What are the tools needed to collect the information? If the data collection method is observation, a checklist or results of diagnostic procedure serve as tools. A checklist is a preset listing of items or activities to which the data collector will note its presence or absence, or whether they are done or not done. The use of checklists is applicable when the objective is to determine the extent to which a set of items or activities which represent the standard are adhered to. This is a checklist of forms that should be present in a TB DOTS facility, the required personnel, required running time, and required equipment, materials, and facilities. It's a questionnaire for a questionnaire. This is a questionnaire that measures patient satisfaction with physical therapy services. It's an interview schedule for an interview. It is a tool used by the interviewer to ask questions and record responses during the personal conduct of personal interviews. This is an example of a household interview schedule. In qualitative research, guide questions are a listing of questions which serve as discussion or observation guides to be used for data collection like focus group discussions, nominal group techniques, or participant observations. This is a guide question for qualitative research regarding experiences and concerns of health workers during the first year of the COVID-19 pandemic. For records review is an abstraction form. This is an example of an abstraction form from a study on dengue hemorrhagic fever. This study on the comparative effectiveness of acupuncture versus physical therapy among patients with knee osteoarthritis provides a summary on the four basic questions in the data collection process. Data to be collected stems from the study objectives, identification of the study variables, and its definition utilizing the total WOMAC score for pain relief, functional ability, and mobility. Pain is defined as the level of intensity experienced during 5 activities on a scale of 0 to 4, 0 as no pain and 4 as extreme pain. Functional ability or difficulty is how well they execute 17 physical activities, on a scale of 0 to 4. And functional mobility or stiffness is the stiffness they feel in the morning and occurring later in the day, again on a scale of 0 to 4. And the total WOMAC index score indicate that higher scores imply worse pain, stiffness, and functional limitations. The data collection method and tool is a questionnaire, the Western Ontario McMaster University's Osteoarthritis Index. There are considerations in choosing a particular data collection method. Practical considerations take into account the limits of time and resources. Types of subjects refer to whether your subjects are individuals, communities, charts, reports, etc. If the objective of the study is on compliance to hand hygiene among emergency department personnel, the most appropriate data collection method is observation. In knowledge attitude practice surveys, questionnaires are used predominantly. But the most important of these considerations is quality of the data. And when we talk of quality, we mean data that is timely. So it's observation over that of records review. If you want data that is complete, you go for interview rather than a questionnaire. Relevance means the inclusion of each item in the data collection tool must be justified in relation to the study objectives and data analysis. Completeness is related to adequacy. The most significant of this is accuracy and precision. Accuracy is how close the measurements or observations are to the true value, while precision is how close the measurements are to each other. Using the dartboard as an analogy, the bull's eye is the true value, while the smaller red dots on the periphery are individual observations or measurements. This figure represents data that is precise but not valid. This figure represents data that is neither precise nor valid. And this speaks of data that is both precise and valid, and this is what we want. Precision is synonymous to repeatability, reliability, or reproducibility. It is the degree to which the results obtained by a measurement and procedure can be replicated. It also refers to the percentage of agreement or consistency between multiple observations, measurements, tests, or responses in regard to the same units of observation. With reference to the type of data collection method, these are the types of reliability. If the data collection method is observation, inter-observer reliability is the agreement in responses or assessments between two or more observers. Intra-observer reliability is getting the same response from the same observer at different observation times. With laboratory data, it refers to inter-test reliability, which is getting the same result on the same specimen sent out to two different laboratories. If the data collection method is an interview, reliability refers to repeat reliability, that is getting the same response to the same question on interviews conducted at different times. In questionnaires, you have test-retest reliability, which is an indication of the stability of responses over time. It involves administering the same questionnaire to the same individuals under the same conditions after some period of time. With inbuilt reliability, the same question, slightly modified, is repeated in another section of the questionnaire, and you get the same results each time. Lack of reliability may result from inaccuracies in the test itself, so to remedy this, instruments should not be defective and should be calibrated frequently. It also results from lack of consistency in what is being measured. So, standardize the condition under which the measurements are made, or take dual or triple measurements. It may also result from changes in the criteria of classification or turnover of the personnel. Avoid such changes and train observers and interviewers intensively. The questionnaire is the most frequently used data collection method and tool in research. If an instrument like a questionnaire is to be utilized in a study, review the research question and objectives. Consider the pros and cons of using one and decide if it is really the best method to obtain the data. There is a need to do a lit search to identify if a previously validated questionnaire exists. If there is, it is advised to use existing questionnaires because not only does it save time and effort in developing one, it also obviates the need to establish validity and reliability of the tool. This is a useful algorithm sourced from a convention speaker. If a tool exists but in a language inapplicable to the target respondent, then it needs to undergo linguistic validation. If a tool exists but there are no validity and reliability measures, then such procedures are warranted. If no appropriate tool exists, one needs to develop the tool. These validation measures, I believe, were discussed on the lecture on tool validation last year. The process of translation or adaptation of a tool begins with obtaining permission to use, modify, and/or reproduce the instrument. Likewise require permission. Always assume that any material that you find is protected by copyright or has licensing restrictions. The aim in translation is to make sure that the translated version conveys the message of the original as closely as possible. So it's conceptual rather than word-for-word equivalence. The process involves forward translation from the source language to the target language, example from English to Tagalog, by at least two independent translators who are both knowledgeable bilinguals, meaning they have experience in translating questionnaires. The translated versions are then reconciled by a panel consisting of the investigator, the translators, and an independent native speaker not involved in the forward translation. The reconciled version is then back translated to the source language by a similarly knowledgeable bilingual. Harmonization is achieved by comparing the back translated version with the original to resolve discrepancies. Validation entails two main processes: content validation by a panel of experts on item relevance, clarity, representativeness, and appropriateness, involving the computation of indices such as your ICVI, SCVI average. And second, on a sample of the intended population to measure comprehension index and conduct cognitive interviews qualitatively assessed by think aloud and verbal probing methods. If no appropriate tool exists, then one needs to develop or design the tool. The process of developing an instrument involves the following steps. In drafting the tool, what type of information are you asking? Is it on attitude? Examples, attitude on immunization or breastfeeding. Is it on belief, like for example, smoking in public and contraceptive use? Is it on behavior, like going for screening? for prenatal care, vaccination, hand washing, or exercise? Is it knowledge about disease or health services? Or is it attribute, which speaks of socio-demographic information? This gives us some sense into what an attitude question looks like and the corresponding response options. This is a belief question, a question on behavior, and an attribute question. Will your questions be open-ended, close-ended, or a combination of both? Will it be in scales? Will it be multiple choice questions? Or will you ask your respondents to rank? The one on the left is an open-ended question and is particularly useful when it is important to hear what respondents have to say in their own words. The close-ended questions have predetermined responses from which participants can choose. Open-ended questions stimulate free thought and is open to probing and clarification, which is missed out in close-ended questions because of response limitations. The chief advantage of closed but a disadvantage of open-ended questions is the ability to code and analyze answers. In closed-ended questions, options or answers are not exhaustive as it does not include all possible options. A compromise approach is to provide an opportunity for respondents to write in brief if none from the response set fits, such as putting others, please explain, or specifying none of the above at the end of the response set. All that apply is not ideal because it does not force the respondent to consider each possible response. Forms of structured or close-ended questions can be numerical or multiple choice, dichotomous, or with an additional option for don't know or not sure, scale or grade. Since the wording of the questions has an important influence on the responses given, the language used should be common, everyday, conversational, and in the vernacular. It should be simple, meaning aim at communicating with the lowest rather than the average educational level of the potential respondent. For example, rather than using over-the-counter medications, it is simpler to ask about drugs you can buy without a doctor's prescription. It should be specific. It should be undemanding. This question provides 21 responses to choose from. From the choices selected, the respondent will have to choose only three, which he will rank from most to least important. Usually, beyond three choices, many people begin to have difficulty. It's either they omit a number or rank two options under the same number. They cannot discriminate if the list becomes too long. A suggestion is to treat each option as a yes-no variable and count the proportion or percentage of times each variable was selected. Unbiased, less judgmental questions suggest a more desirable answer. Relevance pertains to the use of skip patterns for inapplicable questions. The one on the left is an irrelevant question as it has no skip patterns or arrows provided. The question should be non-threatening. Threatening questions are those that involve income, personal hygiene, morality, or sexuality. For threatening or objectionable questions, one can do the following. Soften the manner in which it is asked. Like, for example, do you work rather than do you have a job at present? Or placement. Avoid income questions at the start. For sensitive topics, an introduction is essential. Response style bias is the tendency to respond in a manner without proper regard to the particular question, like responding all agree or all yes to almost all questions, which is known as acquiescence bias. And this is usually observed among those with low education or income. The other type is social desirability bias, which is the tendency to give answers perceived to be socially desirable. The question is about patients' compliance to medications. The top question elicits a socially desirable response, which can be reworded to one that is more likely resistant to response style bias, which is the one below. It is important to give respondents permission to admit certain behaviors without encouraging them to exaggerate. Questions should be unambiguous, avoid use of professional jargon and abbreviations. Other types are use of double-barreled questions. They need to be broken down into separate questions such that each question should contain only one concept. And also questions with double negative, with use of words like lack and not in the same sentence. Other ambiguous questions are those with mismatched question and response choices. To remedy this, either you change the question to how often have you had pain, or change the answer to yes or no. For this particular question, it is unclear how to respond. Disagreeing could mean that the person is often depressed. It can be reworded to the question below. Questions should be answered in terms of the knowledge possessed by the respondents. This means offering an I don't know response, allowing for no opinion, refuse to answer, and not applicable. Response alternatives should be mutually exclusive and exhaustive. Hearing it from a friend or relative or spouse can be hearing it from them while shopping or at work. With regards to sequence, the first part, which is the introduction, should be clear, concise, and relevant. You should identify the investigator, indicate the purpose of the questionnaire, explains how the information obtained will be used, and there is an assurance regarding confidentiality of the responses and anonymity of the respondents, and when the study results can be made available. The initial question should not be off-putting to a respondent, but rather motivate him. Start with easy, salient, non-threatening questions. The question should flow logically from general to specific, from least sensitive to most sensitive, and from factual and behavioral to attitudinal and opinion questions. The transition from one section to the other should be smooth through the use of transition statements. In the body of the questionnaire, standard formats are used appropriately, such as boxes for instructions, arrows for directions, and which questions to skip. The instructions can be placed in a separate manual or included in the questionnaire itself, distinguished from the other questions, by putting them in boxes, writing them in capital letters or italics, or use of other special typefaces. If the format is too complex, respondents or interviewers may skip questions, provide the wrong information, and even refuse to complete the instrument. The acceptable format is more attractive and easier to use, neat, not crowded, and uncluttered. Even if a standardized questionnaire is used, it should be pre-tested in the population being studied, and a reliability coefficient is calculated. Pre-testing is the actual tryout of the questionnaire, conducted ideally in two stages. One is peer review, informally among friends, to detect questions which are ambiguously worded. And second, respondent review, which is on a sample of intended respondents but not part of it. This is followed by interviews or discussions with the respondents to determine their understanding and attitude towards it. With pre-testing, you look for questions which are left unanswered, those with don't know answers, those with answers leading to only one category, those with ambiguous or vague answers, because if there are, you need to change, drop, or replace the question. The results of this pre-testing are incorporated into the rewriting of the questionnaire, and then it's pre-tested again in its new form. As a review, validity could mean any of the following measures. Phase validity involves the expert looking at the items in the questionnaire and agreeing that the test is a valid measure of the concept which is being measured, just on the face of it. For example, whether the dimensions on a satisfaction scale for ER services looks like it actually measures satisfaction. Content validity measures the degree to which the items in an instrument are relevant to and representative of the targeted construct by a panel of experts on the subject. It also assesses clarity and appropriateness. Criterion is the extent of agreement with a standard measure like an interview, physical exam, or another questionnaire. It has two variants, concurrent and predictive. Construct is whether the results of the tool are theoretically sound, and this is often assessed using factor analysis, wherein the construct of interest is multidimensional. The process of validating new instruments is time-consuming and expensive, and worthwhile only if existing instruments are inadequate for the research, question, or population being studied. For reliability, there are three major forms: test-retest, alternate form, and internal consistency. Test-retest involves administering the same instruments, such as a questionnaire, to the same individuals under the same conditions after some period of time, and is estimated via a correlation of scores taken at two time points. Alternate form measures the amount of agreement between two different research instruments on the same construct administered at nearly the same point in time to the computation of couple value of agreement or inter-rater agreement. Internal consistency is estimated via split half reliability index, which is dividing the test into two parts, odd even items, or first half, second half of the items, and administering the two forms to the same group of individuals and correlating their responses. Cronbach's alpha coefficient is a measure of internal consistency among a group of items in a single dimension, and for the dichotomous response scale, it is the Kuder-Richardson formula. So in summary, describe in substantial detail all data collection methods, be it an interview, a questionnaire, a physical examination, or laboratory methods, and provide a copy of the tools used. These are my references. Thank you for listening.